Chest ultrasonography can be a useful diagnostic tool for respiratory physicians. It can be used to complete and widen the general objective examination also in emergency situations, at the patient's bedside. The aim of this document is to promote better knowledge and more widespread use of thoracic ultrasound among respiratory physicians in Italy. This document is focused on basic knowledge of chest ultrasonography technique, physical basis, aims and characteristics, fields of application. Document I shows how chest ultrasonography can be useful to detect and monitor pleural diseases, pleural effusions and pneumothorax, and how it can assess diaphragmatic kinetics and pathologies. Ultrasonography is currently underutilized as an imaging method in the respiratory field in Italy, and this despite the fact that it is an easy-to-learn method with simple, straightforward signs. In reality, given its practicality and non-invasive nature, it can be used to complete and widen the general objective examination so as to facilitate a rapid diagnosis also in emergency situations, at the patient's bedside. In spite of these characteristics, chest ultrasound tends to be more used in emergency departments and intensive care than in respiratory divisions. The aim of this document is to promote a better knowledge and more widespread use of thoracic ultrasound among respiratory physicians in Italy, hence this document is addressed to all fellow specialists involved in the field of respiratory disease. The present document will serve also as a basis for specific training at theoretic level. A following document, Document 2, will deal with advanced approaches to chest ultrasound like in differential diagnosis of sonographic interstitial syndrome, differential diagnosis of cardiogenic and non-cardiogenic acute pulmonary edema, raising diagnostic suspicion of pulmonary embolism, ultrasound characterization of lung consolidations, ultrasound-guided interventional procedures, lung ultrasound in neonatal and pediatric care. Field of use. Although ultrasound can be used to explore multiple districts for different purposes, especially in emergency and intensive care, in the respiratory setting, the routine use of ultrasound is as a tool at the patient's bedside to aid and confirm the diagnosis of diseases suspected following and integrating the objective examination. It can be completed by the common techniques of chest imaging, as well it can help guide eventual interventional procedures that the clinician may decide necessary. 1. The strong points of ultrasonography are as follows. The technique and its sonographic signs are simple to learn. It offers a practical tool to complete and expand the general objective examination, facilitating a rapid diagnosis even in critical conditions. It is useful as a bedside tool, for establishing the pharmacological treatment, monitoring its efficacy, and guiding eventual diagnostic, therapeutic interventional procedures. In the clinical practice of respiratory specialists, thoracic ultrasound can be used to investigate 1. The chest wall, musculoskeletal, subcutaneous structures, etc. 2. Position, morphology and motility of the diaphragm. Evaluation of diaphragmatic excursion and thickness and diagnostics of paresis, paralysis, hypermobility. 3. The pleura. Assessment of pleural effusions, also minimal effusions not visible at standard X-ray, can be identified and estimated volumetrically, detection of adherences and lobulations, characterization of the effusion, corpusculated, non-corpusculated, empyema, secure guiding in diagnostic interventions, thoracentesis, drainage, thoracoscopy. Identification of pneumothorax (PNX), also that which is occult at chest X-ray, especially in patients unable to maintain erect stance. Maximum accuracy in discerning the opacities and obliterations of the costophrenic recesses observed at X-ray, and which cannot be further characterized unless by CT scan. 4. The lung parenchyma. Assessment of echographic interstitial syndrome. Assessment of lung parenchymal consolidations adjacent to the pleural line with identification of air bronchogram, fluid bronchogram, bronchi filled with mucus or other fluid in the context of pulmonary consolidation, evidence of areas of necrosis, abscess, signs at contrast, enhanced ultrasound and their follow-up. Description and characterization of areas of atelectasis. By integrating these assessments with data obtained from echocardiography of the heart and blood vessels, there are numerous clinical situations that can benefit from the use of ultrasound. Integration of the objective examination in unstable, critical patients. Pleuropulmonary assessment, acute lung injury, ALI, acute respiratory distress syndrome, ARDS, severe community-acquired pneumonia, CAP, cardiogenic pulmonary edema. Diagnostic suspicion of pulmonary embolism by an integrated US approach, lung, heart, vein. Estimation of central hypovolemia by evaluation of the inferior vena cava and heart chambers filling 2. Detection, assessment and management of pleural effusions, thoracentesis, ultrasound-guided drainage. Diaphragm kinetics evaluation, in weaning of ventilator-dependent patients. Assessment of pneumothorax, a leading cause of preventable death in trauma patients.